out treatment on large number of patients over a small number of days. So for Colchester Stars in March, we went and visited them and we treated 18 patients in 2 days. We have our Hep C Trust peer support worker, who's Charlotte. So she's now in place to work around the region. She offers support to those who are disengaged and need to engage in the service, or for those on treatment, she can support them through treatment, if that's getting them to hospital appointments, ensuring they can get their medication, or just someone generally to talk to. Then we also have prisons. Last year, we completed 2 prison hits. So a hit is where we would take a team of nurses, pharmacists, Hepatitis C Trust, ODN staff with the aim to test every available prisoner on the day. These hits involve regular planning meetings that take months to bring together the work, and it's a large collaborative working group that plan these. Warren Hill was the first prison hit that took place, and in 1 day we tested 214 prisoners and we found 6 antibody positives and 3 PCR positives. Norwich prison hit took place in February, and across 2 days the team tested 601 prisoners, 6 officers. We found 64 positive or indeterminate results, and 27 of those required treatment. 22 treatments were ordered the same week, and 11 of those were new diagnosis. Our hepatitis C nurses regularly hold clinics within the prisons. And then I'll give you a brief overview of where we are this year. So we have had a run rate allocated for this year, which is 556, and we're currently the highest achieving ODN for treatments from April 2020 to October 2020, and we're achieving 164% against our target. We've had an interesting start to the year. I can't not mention COVID. So we responded to COVID very well. We took the opportunity to re-engage with those disengaged patients. So these are patients that are hard to reach, do not normally respond to letters, messages, or turn up to clinics. So what we did was sent letters out to them. We made phone calls to them. We sent text messages to them and letters to their GP. Our peer support lead, Charlotte, made phone calls to these patients. And through this, we were able to re-engage them into treatment. They were offered telephone clinic appointments, so there was no need for them to leave their house, which seems to have been the key into getting people treated. Medication was posted directly to them as well, which is something we haven't historically been doing. So this slide is some data of where we are. So COVID has impacted on our source of referrals, as many of our partner organisations who we receive referrals from have had restricted opening hours and we're offering a limited service. And we have seen an increase in self-referrals and through our Hepatitis C Trust peer support worker. And that has been through part of our re-engagement exercise we carried out as well. The treatment has been carried out via telephone clinics and secondary care, though we would expect this trend to change as the year progresses and the world adapts to a new normal. The known disease, during the start of lockdown, the emphasis was on treating patients and it was not always possible to stage. However, this will be done during the course of their treatment or at the end of their treatment. So we'd expect this to adapt as the year progresses. And genotyping, during lockdown, we did use a high percentage of pan-genotypic drugs as we were unable to see or bleed patients to determine genotypes. However, we've now got provisions in place to allow us to do so. So going forward, we will be treating according to genotype. One of the more interesting areas that we were able to get into during lockdown was testing in the homeless communities. So as you can see here, there's a picture of the team, and that is the Mayor of Cambridge who came to have his hepatitis C test. So we used a simple, quick testing method, which was an OraSure mouth swab. And if the result was positive, we would carry out a dry blood spot test and follow up with the patient through a telephone clinic. During June to October, we tested 398 members of the community. 28 were antibody positive, and from those 7 were RNA positive and have been referred in for treatment. We've also managed to carry out a hit during the height of lockdown in June. We managed to test in Bedford Prison 161 prisoners, and from that we only found 1 positive. And then these are just a few of the initiatives that have been awarded to us by NHS England and that we're trying to focus on for the remainder of the year. So prisons, again, are a focus. There is 9 within the region. We have two that we'd like to focus on for the rest of the year. So we have H&P High Point and we have Peterborough Prison. So we'd like to complete these by the end of the year, where we'll go in and do some testing on the prisoners. The format may change slightly due to COVID restrictions. However, we are working with the prisons in how we can do this safely. We have community pharmacy. So this is an initiative where pharmacists can test those who inject drugs but are not engaged with our local drug and alcohol services or able to get their testing through their GP surgeries. And the testing will be a point of care testing for antibodies only. Our ODM pharmacist, Paul Selby, is working with the local LPCs to implement this testing. We have the GP PSI tool. This is a tool which can run on GP systems and can be used to identify those who could be at risk of hepatitis C. And from this list generated, we will be able to screen and write to patients to advise them about having a test. This is currently in the stumbling blocks slightly, as we need to work with the CCG to get CSU approval. We do have some GPs who are interested in running the tool, so as soon as we can get CCG approval, we can hopefully be on the way with this one. We have approved premises, so we're moving slightly into probation services here, and this is bail hostels. So we have been awarded some funding this year to test within these services. There are 7 within the region, and they house prisoners who have been newly released on prison or on licence. So we're currently working with our service managers to implement a testing programme throughout the region. And then lastly, we have a community van. So earlier this year, I've placed a bid for a community van along with a driver and a nurse to drive around the entire region and offer testing and treatment from a clinic van. This hopefully will allow us to test and treat in the more rural, unmet areas of need that we have in the region, and where people can't appropriately get to hospitals or surgeries that can provide treatment. So that's all from me for hepatitis C. Now I'm going to hopefully hand over to Janine to do PBC.
Before we do that, Tanina, I think we'll see if anyone's got any specific hepatitis C related questions. We've had one here, which is what barriers did you have to overcome in order to post out hepatitis C medications? And the concern from that person is that their own pharmacy would have difficulties with that. I don't know if you have a comment on that.
I wouldn't know all the barriers. Paul, our lead pharmacist, has been dealing with the postal medication. I know there has been some concern over patients receiving medication. So what we do like to try and do is contact patients a week after medication should be delivered to ensure that it's arrived and they're able to take it, as well as making sure that the records are accurate on our Epic systems here, so it goes to the correct address. So our nurse does in clinic make sure that the address that we have for them is the address they would like the medication to, and then they are followed up with a call after the medication should have been delivered. But I can take your details and I can let our pharmacist make contact with you to clarify how they were able to get around that system.
No, that's great, Tanina, and I think Paul Selby, our pharmacist, has made a couple of comments on the chat room that everyone can see there. From my point of view, the lockdown was helpful in some ways, and this was one of the ways in which it was helpful. So our trust changed to an approach whereby our pharmacy would send out medications for outpatients. So we were able to actually use that facility. And I think, I would say that Paul and I probably have slightly different attitudes to prescribing and dispensing medications and so on. I have a sort of typically gung-ho approach to it, whereas Paul kind of pulls me back in a very sensible way. But by this starting, we were able to get this happy medium, and I think we learned a few lessons. So, for example, making sure that we rang patients before we posted them out to ensure that they were absolutely at that address and they were expecting the medications. I was still concerned that the approach may not work until really recently, when we started to get our SVR results back, and it seems to have been very effective. So I would encourage anyone to start going down the route of posting medications out and having it as one of your one of your methods of reaching out to patients. I think it's been really effective, and I know Paul would be very happy to help and discuss it with anyone who contacts him. We haven't had any other questions around, other than around the medications. What do you think is the single most important thing that we've done to increase our treatment numbers over the last few months, if there is one?
I think one of the most important things that's helped us increase our treatment numbers is the fact that people haven't had to leave their homes to get treated. The patients that we're looking to treat or that have been on our known to service lists for many years are often chaotic patients. And so they seem to have, COVID, I don't know if it's maybe frightened them a little, but it seems to have made them think about their own healthcare and the risks if they don't sort the hepatitis C out. And the fact that they've not had to leave their home to do it seems to have been the most positive thing. They didn't necessarily have to have any extra blood work done. So for a lot of those patients, being bled is often a concern for when they come for treatments as well.
Yeah, I think those are very good points. And Sarah Fairclough has mentioned, it's all about good ODN team working, and I entirely agree with that. Without further ado, we should probably thank you ever so much, Tanina. We're going to move on to Janine, and I've hopefully allowed Janine to be able to share her screen. I hope that's going to be possible, Janine.
I'll give it a go.
Tanina's got your slides, so you can ask her to move on when you like. We'll do it.
Yeah, that's fine. There's only two, so it's going to be very brief. It's just to keep everybody up to date.
Sorry, Janine, you're coming over very loud. I don't know whether you could speak just slightly away from your microphone. That's all, because it's really very loud.
Is that better?
That's perfect. Thank you very much.
Sorry, it was too high.
No, don't you worry. No problem.
So we just wanted, Dr. Miles and I just wanted to give you a brief overview and update to what's happening with the PBC second line treatment and the MDTs. I think we're constantly trying to look at how we change and improve our practice with this. So far, I think we started this in 2018 and we got quite a few referrals from the whole of the Eastern Network. We've had 111 patients through our MDTs at the moment from 2018. The majority, as you see on that slide, the majority have been prescribed obeticholic acid, and then we've had quite a few on bezafibrate. We've had a change, and actually it's been an equal change between changing over from OCA because it didn't work to bezafibrate for some patients and vice versa with some patients. So there has been some flexibility. If it doesn't agree with one option, we can change to a different option. Unfortunately, we have, with this cohort, we have lost 5 patients. We've got 2 on the transplant waiting list and 2 that were transplanted, which is not too bad. So what we just wanted to just do an overview, Titania, if you can change the next slide for me, is just to keep you updated. We are just doing, if you refer your patients to us, the general referral is that they need a raised ALP of above 200, that they have had URSO for the first year and have not responded well to the URSO, or that they've not tolerated the URSO. If you refer them to us, it will just be, I think we've just got a general referral system at the moment. They get to see Dr. Mills as a face-to-face one. We will do an updated fibroscan and ultrasound on that face-to-face visit. They will then be put into the MDT if they're suitable, and then our follow-up will be just 3 monthly telephones. At that point, with everything, this is purely that we are looking at the second line treatment, but we are expecting everybody to still, the patients to be continuing their follow-up with their referral hospitals. We're not expecting to take over that treatment at all, or that patient care per se. We are just monitoring for the second line treatment. With that, we will do that for a year. If they've responded well to the treatment after that year, we will refer them back to their referral hospitals. But we would like, if we could possibly have, to be kept in touch with what their treatment is, and also that we get CC'd into their letters and their blood results. We can't prescribe the Ocaliva unless we've got the obeticholic acid, unless we've got the 6 monthly bloods, just because obviously it's not going to be safe. And the ideal way of doing that is obviously to get their bloods from you guys when you see them on the discharge, on the GP letters. We apologise as well, because there was a bit of a glitch. So we were CCing in our letters, but you weren't receiving our letters. We have now rectified that, and hopefully you will get letters from us as well. Also with that follow-up, what I'm trying to do to put in place, because this is obviously, we're just coming up to the years, and just over the years, we're only just beginning to figure out what we do with the follow-up side of things. But I'm trying to put some guidelines together similar to the ones with the Hep C guidelines, just to say what the expectations of us and for the referral treatment centres to be once we've discharged them from that 3 monthly telephone clinic. I hope that all makes sense. We're also looking, because now we're doing virtual MDTs. We discussed this yesterday in the Liver Eastern Network meeting, was just, and I think it came down quite well, was that actually that the complicated patients, if you wanted to discuss any complicated patients in the MDT, then we could look at doing that as well, and that joining us virtually, and we can send you out some invites to do that. I would suggest, though, if it's possible, that you give us some details about the patients before the presentation, just so that we can set up some notes, and so we've got a record from our point of view of, of what's been discussed. If obviously otherwise, just do it as a general referral letter that when Dr. Mel sees the patients. I think that covers most of what I wanted to say. George, have you got anything to add on that?
No, Janine, that's great, thank you. The only thing I think to mention actually is that Norfolk and Norwich and Basildon are both now prescribing centres in the east of England. And that really has been set up so that no patient has to travel a considerable distance in order to attend their one consultation to have the need for second-line treatment evaluated. So I think with 3 prescribing centres across the east of England, we've essentially got the region covered. And I hope that means that any patient in need of second-line treatment will be able to get it easily.